Hello, Andrew Colsky here with Stop My OCD. And today we have the opportunity to speak to two practitioners who work a lot with OCD, anxiety, and related disorders. So we've got Mary Brizuela and we have Lori Aitken. They both work together. And I'm going to ask Mary if you wouldn't mind starting and introduce yourself to the audience.
Thank you, Andrew. As you said, my name is Mary Brizuela. I'm a licensed mental health counselor in Florida, and I'm the co-owner of Anxiety Center of Tampa.
Great. Thank you. Lori.
Thank you, Andrew. I'm Lori Aitken. I'm also a licensed mental health counselor in Florida and co-owner of Anxiety Center of Tampa with Mary.
Fantastic. How big is Anxiety Center of Tampa?
I think we have, go ahead, Mary.
We got you and me. We started the practice 2019, and then now we have 4 additional therapists, and we have our administrative assistant that works on most of our scheduling and answering phone calls and kind of connecting the client to the therapist.
Great. Thank you for that. So the big question, the first question for me is, how did you all decide to get into treating OCD?
You can take it, Lori.
Yeah, by accident, I guess. So you were an attorney, Andrew. I was a CPA, and the only people that worked harder than we CPAs were the attorneys. And I was miserable, wanted to change careers, went back to psychology, got my master's in psychology, clinical psychology. I was a very psychodynamically oriented program. They never mentioned CBT. This was back in 1990, I think. So my first job, they were teaching cognitive challenging, CBT, things like that. And I was part of an anxiety disorder program, which I really enjoyed. But even then, the people had no idea how to treat OCD. They didn't know how to do ERP. And so gradually I kind of taught myself over the years, and then was lucky enough to work with Patrick McGrath, who is a very well-known, OCD expert. I worked, the same place he did and started learning from him. And then, again, attending trainings, things like that. Then when I moved to Florida, I lived briefly in Jacksonville, and I met, Mike Batter, Kim Vincente. I was on the board of OCD Jax. They were kind enough to sponsor me to go to the IOCDF's BTTI, Behavioral Therapy Training Institute, which was wonderful. Then we moved to Tampa, and I got a job at Rogers Behavioral Health, which is where I met Mary. And we both worked in the intensive outpatient program for anxiety and OCD, and did, heavy ERP. And so that's when I felt like I really, kind of just got ERP, very comfortable treating it. I stayed there about a year, and then we opened, we started the process of opening our own place.
Yes, the part she left out was that on the first day, we both started on the very first day together. We were both in the same training, and we went to lunch, and casually we just said, oh, wouldn't it be cool if we had a private practice one day? And then both of us were like, yeah, sure, that'd be great. And
let's do it.
A year later we were talking about it, and another barely 6 months later we were doing it, and now we've been in practice for over 4 years now.
And we were busy the day we opened our doors, and it has not slowed down.
Right.
At all. So we've been very fortunate.
Yeah. Well, I mean, it's an area that, is sorely needed, and you certainly both seem to have some really solid background on it. Mary, I'd love to hear more about your background as well, but I know working at Rogers and all, you probably got really good training there. So tell us about you.
My background is a little different. I went straight into psychology from college, and I did work in different areas of mental health. Right before I was at Rogers, I worked in substance abuse. And before that, I worked in a partial hospitalization program for people with severe schizophrenia and bipolar.
Ooh.
So enjoyed all of them, but they were not anything that I was feeling like I could do for a long time. After I worked in substance abuse here in Florida, I started looking for jobs again, and I found a job at Rogers Behavioral Health, and I immediately fell in love with ERP specifically because it fits my personality so well. And not only was it ERP that I fell in love with, it was being able to help people doing ERP, using my personality to help people get better. And then I saw people getting better. So then I myself I trained at Rogers, but then I did some trainings on my own. I also did BTTI, and then working with Lori and opening the practice. That was also a different type of treatment, just because it was at the outpatient level, not at the PHP or IOP. So it's been a growing process for me, but I feel very confident in what I do. If I don't feel very confident in other things yet, like ICBT, which is something I'm sure we'll talk about later, but ERP is my passion, and I love treating OCD and anxiety disorders. And that's pretty much how we've gotten to today, to like a practice of 6 now.
I just want to say that in the interview for Rogers,
Mhm.
I was not asked this because I think they knew a little bit about my background, but I remember, Mary, you said that Dr. Eric Storch asked you if you'd be comfortable with a patient holding a sharp knife to your throat.
Yeah, and I said, I guess, sure, why not? And I obviously thought it was a trick question. But in my head, I was like, this is a weird question to ask. It has to be a yes. If I say no, then this probably doesn't make sense. And I remember thinking in my head, well, why would somebody hold a knife to my neck? It's probably because they're obviously fear of harm and all that. So up front, that was a very interesting question. I definitely went home and I told everybody about my interview. But after that, I mean, that's happened a few times there and at the practice. Not totally irrelevant.
No, I love that, because it's so interesting to hear. I hear the Pat McGrath stories in the background as you all are talking. And I started my OCD training by taking some webinars that he had done. So it was recorded, so obviously he never met me. I just saw him. I did do a little consult group with him live, so I did get the opportunity to meet him. He's great. I mean,
Yeah, he is awesome.
he knows what he's doing, and he's got a great personality. But I hear his stories now,
Yeah.
But here's a question that I have for both of you, because it's a question that I ask every single practitioner, whether they be a psychiatrist, a psychologist, or a mental health counselor, and I always get the same answer. And I bet I'm going to still bat 1,000 here. Did either of you in your school, in your master's program, learn anything at all about OCD?
Not the correct.
I'm sorry, go ahead.
Well, that not the correct thing. I don't think we learned. I wasn't taught what OCD is the way that I know it now. You always hear about it, like the cute and the quirky and the touching doorknobs, always touching the doorknobs. That's like the main thing that they would always talk about. Obsessions and compulsions, but not in the way that it actually presents in day-to-day life. So not for me, no. How about you, Lori?
No, I had a class on, I think it was, I don't know, psychopathology, but it was all about schizophrenia, bipolar disorder, things that, yes, I have worked with in the past, but OCD was just never mentioned. And it is such a disabling disorder for people. They may have said something in passing, but like I said, they never even taught me anything about CBT. So, anything helpful about ERP or OCD was just not there.
Yeah, and that's the answer I get from everybody. I have not had anybody yet say to me, "Oh, absolutely, we've had a whole segment on that." nobody has had any experience with it. And so I get a lot of questions and just parts of conversations with clients and family members. And they say, you know, I went to this therapist and they said they did OCD, but they didn't do it the way this is and all that. And I said, you know, the challenge here is not that any of these therapists or psychiatrists are bad people. They just haven't learned it. You know, they didn't have the opportunity. Nobody ever taught it to them. And unless you specifically reach out to go and get the training, you're not going to have the training. So,
And I was going to say, that's why it's, you know, an average of 17 years from the onset of symptoms to, you know, finding the right treatment. And a lot of therapists who are not trained, and I know I was guilty of this when I didn't know how to treat it, we end up co-compulsing with the client, engaging in figuring out compulsions and trying to, you know, we do a lot of things that are just counterproductive, not helpful, because we don't know any better.
Right. Right.
I think the only reason I was prepared for the interview that I had at Rogers was, number one, because if I'm going to interview somewhere, I'm going to research the company, I'm going to research what they do. And I'll never forget reading from their website, the Rogers website, some of the things they were talking about and the subtypes of OCD, and thinking, I can't believe that there's this many. And I also I looked through like LinkedIn and who worked at Rogers, and I knew somebody that worked there just through like, it was like a counselor group. And I emailed her asking her if she had any advice, if there was anything I should like read up on or research. And she gave me some ideas, some things I should like learn about. And that's the only reason why I feel I went in there pretty prepared and ready to learn, because I took an extra step to educate myself before I got there. But even up to today, we've had a couple students that interviewed, even Sophie that just graduated a couple years ago. Like, schools are still not teaching what they have to teach for OCD, and it's so prevalent. It's not like it's one of those things that it's like very uncommon. It's very common, and it's chalked up to something, a quirk that somebody has,
or just not recognized at all. I mean, especially I know they used to call it Puro, but that, you know, were primarily, you know, mental obsessions and compulsions. You know, those can be tricky to recognize. And so, you know, it's easy, you know, it's easier to recognize the overt compulsions. I'm washing my hands and they're red and raw, but it's definitely, there's a lot to be aware of and to know. And it's a shame that people are not taught.
Yeah, you know, there's one story, I've told it on a different podcast, but, you know, just briefly here, because it's so relevant, you know, I still to this day do not have a solid psychiatrist that I can recommend patients see who truly understands OCD. And at one point, you know, I had a patient who wanted to go explore medication to assist in the therapy. And I gave him the name of a psychiatrist that someone else had given me. And I said, you know, I can't tell you what this person knows about OCD, but it's a name. And he went and he came back to me the next session and he said, now this is a guy that had mental compulsions. He said, well, I spoke to the psychiatrist, but they told me that I don't have OCD because I'm not doing any physical compulsions. And I was just like, and I didn't recommend, I said, this is a name of someone, but still it was like, oh my gosh, you know, that's wow.
Yeah. And I think even more heartbreaking than that are the people who have, you know, suicidal OCD or harm OCD, who share some of their thoughts with the wrong person and then get hospitalized. That's heartbreaking.
That's happened to my patient and a couple of my patients, but one specifically comes to mind. He finally just felt comfortable talking about what he was struggling with, and the cops were called and he was hospitalized. Not hospitalized, he was arrested, and then you know they took him, but he was arrested because for aggression or homicidal ideation. And It's just, it's things that I don't expect every single person to know. I think under the circumstances, I think if you start dating somebody and they share these things, I can understand general fear. You know, that's where we have a discussion about boundaries and who to share this with. But you shouldn't have that trouble with your family members, your family, like your friends, and your workplace. They should be knowledgeable about things like this, because it's very different for somebody with OCD to say, I'm having intrusive thoughts about harming someone.
Well, and even especially the people at the hospital, that
Exactly.
admitted him,
Mhm.
they should
Exactly.
at the very minimum recognize it.
Yep. Yep. I have in my intakes, when I start sensing that someone, especially if they have no idea what OCD is, or they tell me that they just suspect that it's OCD because they did some Googling. Um, if they start struggling to tell me what they are struggling with, I just start giving off a list of all the subtypes, because this most of them don't want to come in here and say, I'm having intrusive pedophilic thoughts. I'm
Right.
having intrusive thoughts of killing my mom. And so I just start listing them off for them so that they know, I already know what you're thinking. So I'm just going to say it so that you don't feel scared to say it to me here.
Right.
And immediately the reaction is always, "Oh, I didn't know that you
Such
were."
relief. Yeah.
It's always relief. You see it right away, and it makes you feel honestly upset that this is not something that they knew already, so that they wouldn't feel so alone.
Yeah.
Even another thing that's so powerful is in our support groups, people would be very honest and open about their specific compulsions, whether it was fear of, bestiality or pedophilia or whatever. So to hear, to have someone new in the group and hear, oh my gosh, all these other people are having these bizarre thoughts. It's not just me.
Mhm.
And it's just so normalizing, and talk about not feeling alone. I'm sure you've had that in your support group.
Yeah, and that's one of the reasons that I do these podcasts, is so that people can see, oh, look, there's somebody just like me.
Yeah.
Maybe I have OCD, and they can, then find the help that they need.
Mhm.
But it is challenging because, one of the things that I find, even through doing the podcasts and the educational videos that I put out, is if I put out, or not if, when I put out something related to pedophile OCD, I actually have to turn off the ability to comment,
Yeah.
because even though I am very clear that someone who has pedophile OCD is not a pedophile, does not want to be a pedophile, would never be a pedophile, they don't hear that. They hear the word
Yeah.
pedophile,
Yep.
and then you get these, remarks that are just inappropriate.
Yeah.
So,
And
it is a stigma.
Mhm.
as a mom, when I have another mom or another dad or a parent sitting across from me telling me how much they struggle being around their child, that breaks my heart for them so much, because it nobody understands how difficult it must be to struggle with these thoughts that are fear inducing, so much so to the degree that you will avoid your child or avoid being around your family. And it's important, I think it's important also to at least clarify that the content of the thoughts, like whether it's harm OCD or any of the lesser talked about topics, the content is not the OCD, it's the reaction and engagement to the thought. Because all intrusive thoughts are very common across any single person. If you have, like, talking about pedophilia in general, talking about fear about harm, or I just said earlier, like, what if I had an intrusive thought of killing my mother? Like, that's an intrusive thought. It's hard not to have a tangent thought to that statement. It's more so what the person with OCD feels like they need to do, or what that means about them, that then cause that's what the OCD is. Most people will have a thought like that and be like, okay, well, that was weird, and move on. Forget about it. They might not even notice it. The OCD is the engagement and the problem it causes. And so
Mhm.
that's important to note, because a lot of people with OCD, or a lot of my patients that I've come across, they think that they're the only ones with these thoughts, and that's why they have OCD, and that's not the case.
Right, right. Well, I want to, talk a little bit about some of the treatments in a second here, but just a comment about what we were talking about there first, which is, when someone, if someone is watching this video who thinks they may have OCD, or maybe they have a family member who may have OCD, if someone is talking about, thoughts of harming someone, or thoughts of touching a child, or thoughts of, any of the things we're talking about, if they have a lot of distress about it, it's probably OCD, because they have this thought that they would do something that they know that they would never do. That's not who they are. That's not what they would do. And that causes this distress. And that's very different from someone who says, I want to go and harm somebody. I am looking forward to it. Boy, wouldn't it feel good to be powerful? That's a totally different thing. So
they're afraid of the thoughts.
right, exactly. So
Afraid
with
of the
that,
thought and why they're having that thought, and they question themselves and their intention, but
yes.
not their desire to.
Right. And so I introduced that because what I'd like to do is, I'm going to go to Mary first, because I'd love it if you could share with the audience a little bit about your experience with exposure and response prevention, and how that works, and how you use it in your practice. And then after that, I'd love for Lori to talk more about inference-based cognitive behavioral therapy, which is a different approach. And it's just important to understand the different approaches that are available. So Mary, what about ERP?
So ERP, like I said, ERP is exposure and response prevention. And like I said earlier, my first time even learning about this was in right before 2000. It was like 2009, no, 2017. Oh my gosh, I lost track of time. 2017. And like I said before, I immediately fell in love with it, just because I really loved the structured approach, the creativity, the collaboration with the client. And so essentially you take the client's OCD categories and you make a hierarchy of exposures that would be appropriate for that category, that would help them re-engage in their lifestyle the way that they did prior to the OCD taking over. So in our practice, the way that I do ERP is, a lot of the times people step down from a higher level of care. A lot of times this is the first person that they're talking to about OCD, or unfortunately, a lot of times it's also, they've been to a bunch of different therapists where they've had talk therapy, where they've challenged the anxiety away, or reasoned it away. Like, I would never harm anybody, or you would never like wash your hands. There's no way that there's contaminants on your hands. And they find their way eventually to us after failed attempts. And so like I said earlier, it really matches my personality, because I like humor. I like being friendly. I like stepping outside of the box. And so I try to get my client out of the office as much as possible. We have our practice, and it's facing a development. And so we picked this practice because this development was coming there. So our practice started, and then there was nothing built. And then a year later, there was everything built. So there's a Whole Foods, there's restaurants, there's stores. And so we cross the street and we get to do a whole bunch of things out there. I'm always at the Whole Foods or up the elevator. And so I always meet with the client. What are you willing to do? What is OCD impairing you from doing in your day-to-day? Because I do believe it should be relevant, and exposure should be relevant to their life. I don't think it's necessarily, at least at the outpatient level, where I see them for 50 minutes a week. I don't want to waste time on things that are like out of this world, exotic, and on paper they seem like really cool, but in practice it's not really necessary. I want to get them functional again. And then after they're functional, if we want to push the envelope a little bit further and do some kind of wild stuff, then for sure I'm down. But up front, I know that those 50 minutes are very, very precious, and I need to not only check in with them, get them engaged, practice exposures, check out, and then have them come back next week with enough time to talk about the week in between, hold accountability, and then eventually pass that accountability onto them.
Yeah. So one question for you before we switch over to Lori, with in my experience with my clients, I typically tell them that OCD treatment versus other types of mental health treatment, in my experience, I find that OCD treatment has pretty good success rates and it takes a lot less time than some other things.
Mhm.
Is that your experience too, that it goes relatively quickly? I don't mean in a week, but I mean compared to other disorders, it seems to go pretty quick.
I would agree with that for the most part. And I do think what's important to say with that is that if they are motivated and they're willing to be uncomfortable and they're willing to challenge themselves, then it happens very quick because the steps are very tangible. So you'll see the changes right away. If
Mhm.
if you're not washing your hands when you really, really want to, an urge goes away in 20 minutes. So you will start saying, oh, the 20 minutes passed and I didn't actually need to do it again. Maybe if I do it one more time, it'll happen again. But most people don't give themselves 20 minutes. So they're stuck in their rituals right away. So if we can just elongate that or delay that ritual, they start seeing, actually, this is not that bad. I could probably handle this. I'll try it again. And so that's where I do tell them, you will probably see not immediate, like tomorrow, but you'll probably see very quick results, like in the next couple weeks. Honestly, probably it could be even less if you really are doing it. It might take longer to maintain, like we might have to be doing this for a little bit to maintain it, but you might start seeing that reduction in anxiety right away because, like I said, it's a very tangible therapy and the changes that you make are impactful.
Yeah, and I think that's pretty much,
Mhm.
across the board, the same experience that other people have
Mhm.
with ERP as well. But I am very interested to hear from Lori now about ICBT. What the heck is it, and how does it work, and what's your experience?
So, gosh, that's a lot. I'm by no means an expert in ICBT. It was developed by Kieran O'Connor and Fred Artema,
Mhm.
and they have done a lot of research on this method. It's Dr. Artema's research in Montreal has shown that it is as effective as ERP. It's been used throughout the world for probably 10 or 15 years successfully. It really only came to the United States, and only in the last couple of years has it really blown up. I was made aware of it in a Facebook group for OCD specialists, and someone said, "Hey, check out ICBT, inference-based CBT," and I was like, "Oh, what is this?" So I joined their Facebook group. At the time, on the therapist listing of people in the United States who did this, there was one name,
Hmm.
one guy in the United States. Now I can't even tell you how many are on there, but I mean, this was less than 2 years ago. So, there was a very small group of us, largely comprised of practitioners who had used this method to overcome their own OCD.
Mhm.
So that was, a very, gave it a lot of credibility to me. So we started meeting every Friday, very informally, just to talk about it. Dr. Artema was, kind enough to be part of that and explain it to us. And then at some point we started having people present, each module. There are 12 modules. You can find all of this on the website. It's icbt.online. There's all the information for the 12 modules. There are videos of panel discussion or presentations for all the 12 modules. There
Mhm.
are also panel discussions where, after we went through all the modules, we started having clinicians present how they work with that particular model. And the people in that group are so creative. There are so many visuals and handouts and videos and demonstrations. It's just someone can go on there and really pretty much get access to everything about ICBT. So I highly recommend that. So I started being, in that group. I was reading the treatment manual, and it made intuitive sense to me from the beginning, because I had experience with some clients who had done intensive ERP and gotten worse and came to me, and it was like, okay, well, I know ERP has not helped you. What else are we going to do? And so I worked with them, not with ICBT, but maybe in a similar way. And the goal was to help them see that they could trust themselves. I think that's the goal of ICBT, is self-trust. And so I don't know how much you want me to explain ICBT, but just here's an example. So the person who came to me had been in intensive treatment. He was afraid he was going to kill his children. He had moved out of the house, so he would avoid them. And through the intensive, that got worse and worse and worse. He had been trained in ERP to say, well, maybe I'll kill them and maybe I won't. And I know everyone does ERP differently, but with that particular way of doing it, I really dislike that because, and I've told him, I don't wake up in the morning thinking maybe I'm going to kill my husband today and maybe I won't, and I have to sit with that uncertainty, right? I mean, anything is possible, but I can trust myself that I don't have to, I'm not going to do that. So kind of working on seeing, so ICBT is a form of cognitive behavioral therapy, but we're not challenging, we're not trying to talk clients out of their OCD and fight with the OCD. What we're trying to do is help them understand the reasoning process that created we call it the obsessional narrative or the OCD story, and learn how not to reason their way into OCD. So we go through, and it is a very cognitive approach. We go through and help them understand how, based on this vulnerable self theme or who they're afraid they might be, OCD then latches onto specific themes. The themes aren't random. If you're afraid that you're a really negligent person, your negligence themes and harm themes, are going to be everywhere. So we help them see how that really is the exact opposite of who they are. And there's a lot of steps to all of this. But we also help them see how there's a difference between obsessional doubt and reasonable doubt. So reasonable doubt, one example that we use is a reasonable doubt might be, I see there's a patch on my skin. What if it's skin cancer? Go to the doctor, have a biopsy. I'm going to have some reasonable doubt while I'm waiting for those biopsy results. Is it cancer? I don't know. I have to tolerate that uncertainty. We do that all the time in every area of our lives. Obsessional doubt would be same situation. I go, I have the biopsy, I get the biopsy results, and I say, and they're negative, and I say, but what if they messed up the test results? What if they didn't, what if they mixed them up with someone else? What if I have a type of skin cancer nobody recognizes? It's just this endless loop. And we help people see that they reason differently in the area of their OCD theme than they do in every other area of their life. Right. So they may be terrified that, oh gosh, I can't even think of something, but that they're going to, get ALS or a deadly disease, and constantly body checking and researching and everything else. And, it's like, well, it's possible. And I say, okay, well, it's possible, someone's going to walk in the door with a gun and shoot us. Have you been sitting here this whole time worrying about that? And they'll say, well, no. It's like, okay, so anything's possible, but your OCD is focused on these specific possibilities that stems from this vulnerable self theme. And so we try and teach people to recognize when they're triggered, when they're starting to, as we say, leave reality and cross the bridge into imagination. Because inferential confusion is confusing reality and imagination.
Right.
So once you're in the obsessional bubble in your imagination, it's really hard to get out. But you can learn to recognize when you're crossing that bridge and how to say, wait a minute, I have a choice. Am I going to go into the bubble or am I going to go back to reality? So we do, reality sensing. We help them try and focus on using senses and their sense. So, okay, you're afraid that you hit someone while you were driving. Well, did you hear anything? Did you see anything? Did you feel anything? Kind of in a way like, it's not the same as thought challenging, but, what do your senses tell you? What does your common sense tell you? And we look at the reasoning errors in OCD and how OCD tricks you like a con man into believing that these facts taken out of context are actually relevant to the here and now. And we kind of look at why that's not true. Just because someone else, was arrested for hit and run doesn't mean you ran over someone. And so we go through different reasoning categories and help them, like I said, trust that we help them look at who they really are compared to who they're afraid they are, and learn to trust themselves in areas of obsessional doubt. So the goal is to resolve the doubt rather than to habituate to it or to accept uncertainty. And often we can do, I'd say we do need to, when we do the reality sensing, they do work on not doing the habitual compulsions. And so that is there's some response prevention there, because there's a void. If I've always done this, it's, there's going to be a void and a yucky feeling if I don't do it. But again, so there's some response prevention there. And then, we will do exposures, if so for someone with hit and run, we'll go through the ICBT sequence. And then, just to get them back in their life, let's go driving. Let's go, do the things you've been avoiding. So I don't know if that's consistent with your understanding, Andrew, but.
Totally.
I think, Lori, that I finally, I understand now why you said that it's intuitive for you, because a lot of what you just explained is what I learned recently, and from you sharing things with me, because I'll pick Lori's brain when we have time so she can explain a bit to me. And I've noticed that a lot of the ways that ICBT explains OCD and how it works is how I would tell them in an example how OCD tricks you into believing that this is the reasonable way, or the obsessional doubt versus the reasonable doubt. I remember prior to knowing ICBT, I would try to figure out a way to explain to them in a way that they could make sense of it. And a lot of that has come through ICBT. So I feel like right now is when I realize why I get that you said that it came very intuitive to you, because a lot of it just makes perfect sense in the way that OCD is explained.
Yeah. And one of my favorite examples is when we were doing intensive ERP, I had a woman who had harm OCD, walk around holding a knife with fake blood all on her arm, a piece of sausage on the end, telling people she had killed her family, and then going in the waiting room, waiting for the police to come and arrest her. And I mean, it was horrible. And a couple of years later, she came to see me for an unrelated issue, here at Anxiety Center. And she said, we were talking about her exposure. She said, you know, the thing that made the most difference was not necessarily the exposures, but it was when I was holding a knife to your neck and you said something along the lines of, do you really think I would let you do this if I thought you were going to stab me? And at the time, I was like, oh, I shouldn't have said that. That's reassurance seeking. But that was what stuck with her as, you know, that's not who she is and it's not what she's going to do. And that's in line with ICBT.
Yeah. Yeah.
And that's why, I don't know, that's just why I'm so drawn to it. We kind of pulled, I explain it like it's the Wizard of Oz or like it's a magic trick. Somebody makes an elephant disappear and you're like, oh my God, you know, that really disappeared. And then you go backstage and they show you every step along the way to how they did that.
Mhm.
And you can't go back to believing that it's real. And so
Right.
when we explain you know, and really go through in detail this whole process and people see it, you can't unsee it.
Yeah. Well, it's, you know, the one thing that I love about this particular conversation and the fact that we have three of us here is because here's three therapists, all who treat OCD, all who have the same understanding of OCD. Mary prefers ERP. It fits with her personality. It fits with her way of treating. Lori prefers ICBT for the same reason. And I tend to be the middle person because I have a process, you know, for myself that I call DRILL, doubt reduction and inhibitory learning. And it uses both ICBT and exposure. And none of us is right and none of us is wrong. It's just three different right ways to do therapy.
Mhm.
And, you know, that's the thing is, you know, especially with clients who have perfection issues and they're always looking for the right way.
Yes.
One of the first things I tell them is, well, let's change the language a little bit. Instead of the right way, how about a right way? And when you change that
Yes.
language, it immediately opens up to them that, oh my God, there could be more than one right way.
Mhm.
And therapy flows more easily from there.
And
So
why
I
shouldn't there be?
agree.
Why
Um,
shouldn't there be more than one right way? If you have a headache, you have the
Mhm.
option of several headache medicines. Why should there only be one way to treat OCD?
Mhm.
Especially when
Yeah.
a lot of people don't benefit from one medication or if there are options and we can find which option is best for them, then we are doing our job. And if we are not doing that for them, then we are doing them a disservice.
Yeah, and when someone comes in, I will spend quite a bit of time saying this is ERP if they're not familiar with it. This is ICBT. You know, go home, look at, you know, some of these materials and then let's talk about which one resonates more for you. Some people choose ERP and that's great and I can do that. And some people, you know, are too afraid to do exposures. Some people have had bad experience or bad luck with ERP. So, you know, I say, hey, I have a lot of tools in my toolbox. And if one doesn't work, let's throw that out and try something else, you know, and I'll say, okay, if you failed this treatment, you didn't necessarily fail the treatment. Maybe the treatment failed you by not being flexible enough to, you know, figure out what it is that you need and work with that.
Mhm. Well, I'd love to do a little exercise here. Again, because we have three therapists, it's unusual for me to have this. I'd love to hear a success story, like an unusual or a unique success story from each of you. But I'm going to start and I'm going to share one of my own so you get the concept of what I'm talking about. So, granted, this particular story, it's true, but it's very unusual. So it's not the norm. But I had a client who I had my very first meeting with him about OCD treatment. I provided some psychoeducation. I provided some of the information like Lori was just explaining about the, you know, when we move over into the obsessive doubt and when we have the factual here and now in the senses. And I went through the whole thing, kind of explained the whole big picture of OCD. And our next meeting was supposed to be for us to start doing some other work. I meet with him the second time, And literally he says to me, this is after one meeting, he said, you know what? I thought a lot about what you said and I really understood it. And I don't have the problem anymore. I don't need to do the next step. And I was like, wow. I mean, now again, that's very unusual. It's not the norm. I didn't do anything magical. It just educated him. But that was sort of a really interesting case. So I wonder if either of you have any interesting things that you've had in your own practice.
I have a recent client that I have success stories that are like long and you working towards it and they finally got better, but similar to this one, and I'll share it because I want people to see that it's not very uncommon. And it's not the norm, but it's not uncommon, but it's pretty similar. This client of mine started about 2 months ago. And after the first session, I said, this is probably going to be my third most severe case. Because I have a hierarchy in my mind. And like, this is going to be the third most severe case I've pretty much ever seen. With everything that she told me and everything we went through, I talked to her. We like, if you're open to it, we can meet more than once a week. Let's figure out a schedule that works for both of us. She was absolutely for it, super motivated. She had contamination, severe contamination, OCD, fear of hit and run. We went through psychoeducation, same thing. We set up some very specific exposures around her shower routine that only targeted the entrance part, like entering into the shower. And it's not 2 months later. And like 4 weeks ago already, I was telling her, I think we're gonna have to go down to biweekly. You're just doing everything and really doing it correctly. And in my mind, I started doubting. I was like, there has to be something missing. Is she not telling me something? Is she hiding it? I said, we're gonna do a session we're gonna do a telehealth session. You're gonna black out your screen. You're gonna just basically close it out. But you're gonna go do a shower. You're gonna come back. I'm gonna time you. She took a shower in like 7 minutes. Her hair was washed, everything. I was like, I cannot believe this. I could not believe what I was seeing. Everything she was telling me. And it's not that I was doubting her. It's that I was surprised at how quickly this can work. And so I don't think it has to do with severity so much as motivation. And I've told my clients this. I tell almost all my clients this, that it could be a fact. There could be a survey they send to the whole entire world, and it could say Mary is the best therapist in the world. And that wouldn't matter if you are not doing your part. So this is not about me. I'm just here to give you the information that I've got so that you can do my job. And if you do that, then we're good. And I saw that, and that was just so impressive to me. And I still meet with her because it's only been 2 months. And so we're kind of like passing into maintenance, but that was amazing to me.
That's fantastic. That's the reason that I do OCD treatment, is because, yeah, they're not all going to be that fast, but you get that same feeling because you see the success happen and you see them go from this horribly distressed person to someone who doesn't have that distress anymore. So what about Lori? What about you?
So for me, I don't want to, rip on ERP because it can be very, very effective. I think where I'm kind of finding my groove now with the ICBT and coming from a psychodynamic background and things like that is the utility of finding that vulnerable self theme, and then looking at where it comes from and seeing how often, I think I had mentioned earlier, was 76% of people have comorbid OCD and PTSD. So I end up, it's not a story yet, but sometimes we, have to treat the PTSD first. Sometimes we just need to recognize where this comes from, and sometimes we resolve the OCD symptoms and then come back to kind of where this comes from. So one story that went pretty quickly, this woman had just, she was on the verge of you know, her boyfriend was on the verge of ending the relationship because of her constant reassurance seeking, pathological jealousy, checking, all of this. And so we started work. She was one of my first ICBT clients. We started working through it, and, you know, we started looking at the vulnerable self theme, and it became apparent that, you know, a past boyfriend cheating on her and her staying in the relationship in spite of that, you know, led to her distrusting that she would A, know when something was wrong, and B, have the courage to leave. So she was always, you know, her vulnerable self theme is, I'm going to get stuck in this relationship just like I did in the last relationship. There was a lot of trauma from that because it was very abusive, manipulative. So we had to kind of take a break from ICBT, go into that, kind of work through a lot of that, build that trust that, okay, these are healthy, these are warning signs, you know, versus obsessional doubt. You know, these are, you know, you can trust yourself that if you see these things, you know, we can talk about this, and you're strong enough to get out, those kind of things. And once she understood that, and even we had her boyfriend in for a session, and when she was able to communicate that, and he was able to see, wow, this has nothing to do with me. She's not, you know, interrogating me because she doesn't trust me. You know, then everything opened up. They were able to, you know, come up together with some response prevention for reassurance seeking. And she really, the OCD, I don't want to say it went away overnight, but it just resolved so quickly once she saw where it was coming from, why it was there, and that it really wasn't necessary.
Wow. Wow. You know, this should be, you know, good for someone to hear who's watching this podcast, who may think they have OCD, and maybe they've heard about, you know, ERP, and they're afraid. I don't want to expose myself. I'm so afraid of the distress. That, you know, there's other options, and ERP by itself is not as bad as you imagine it might be, because like Mary said, you do this hierarchy and you work your way up, but
And
there's so many
sorry.
options. Go ahead.
I just want to say, in her case, she had tried ERP, but she couldn't find any exposures to recreate the anxiety because she knew they were exposures. So, you know, it's like, okay, well, this is not working for me. So it's like, that was, I think, really one of my first, let's try this alternate approach. And for
Right.
her, that clicked and just worked really well.
Yeah, and that's fantastic, and that's, like I said, that's sort of the purpose of this, is to make people aware there are and there's even more options than what we're just talking about, but these are definitely two of the major, you know, players when we talk about therapy for OCD.
I think they're the most evidence-based to date, the most studied.
I'll say something in regards to what you just said, that there are a lot of people that are afraid of ERP, and just like people have done OCD treatment incorrectly, like doing talk therapy instead of an evidence-based treatment for OCD, I do think that it's important that a therapist doing ERP have certain qualities, and those need to be that they are holding their patient accountable, yes, and pushing them, yes, but they have to be compassionate. Like, this is what you might find silly to do is absolutely detrimental to them and their mental health. Like, this is difficult for them. So you need to understand that these things are very, very difficult for them. And if they tell you, stop, this is not okay, I need to bring it back a bit, they're paying you to be there, and you're not there. They're not paying you to push them further than they need to be pushed. You will get there. And if you build that trust, that's more important than anything else. Then they might be willing to say right away or much quicker, okay, you know what? That did work out last time. Maybe we can push this one a little bit further this time. And you just need a quick buy-in. You've seen these three stories right now very differently. all you needed was the patient to buy into it and see it happen one time, see it work one time, to realize if I do this more often, it might apply every other time. So I wanted to say that because I think a big reason people are afraid of ERP is because of the push and the like exotic exposures. And while those can be helpful eventually, I don't think it's necessarily the most important up front when you're trying to get people to buy into the treatment. And that's been in my experience now.
I totally agree that, you know, it's the compassion, it's the relationship, you know, as they always say with therapy, but it really is, if they trust you, they trust they're in control, they can stop whenever they want, because, you know, OCD is so much a fear of not being in control, often losing control. So I think they need to be able to say, stop, I don't want to do this. This is too much. And then once they trust that you'll respect that boundary, even though you might gently encourage, but if you really respect that stop, then they'll be more willing to try harder things when they're ready, which is what I think Mary was saying.
Yeah, absolutely. I mean, I push in the way that is therapeutic, because they're missing that part for themselves. ERP is common sense at the end of the day. The part that's missing in the common sense is somebody to hold you accountable to it up front, so that you can see the payout or the payoff. I mean, for, you know, what that habituation feels like. And so I will push, but at the end of the day, this is their treatment. It needs to go at their pace. And once you start getting to know them a little bit more, if you know that they're not pushing themselves enough, but you know that they can do more, you can tell them, listen, I know we can do more than this. And if you can't, then give me an alternative. What can you do instead?
Right.
Yeah.
Well, this is such a perfect setup for the next question I was going to ask you all, and maybe it'll be our final question, but let me just give a little bit more of a setup here. So I agree with you 100%. I always tell my clients, we're never going to do anything that you're not ready for, so that it gives them a degree of comfort that they're not going to get pushed beyond, you know, where they are. But that leads to this question. Whether we're talking to a therapist who is considering learning to treat OCD, or whether we're talking to a loved one, a family member of someone who is living with OCD, the concept of we know the person with OCD is experiencing distress, but I hear from therapists, well, I don't want to do OCD therapy because I don't want to make someone feel distressed when we're talking about ERP. So there's that concern. And the same thing from a parent or a loved one who accommodates. Well, I don't want to stop accommodating because it'll make them feel stressed. So the question to each of you is, what comments and advice do you have on that, either to a therapist considering treating or a loved one?
Well, I can start with that one. I think that, you know, the client's already in distress. I think from, you know, what I always try and get the family to come in, and again, giving the client agency. I try and agree, you know, have the client and the family member agree, this is what we're going to do when you seek reassurance. So if it's agreed upon ahead of time, just like in therapy, the client knows that this is part of the plan. It's not just the family member saying, no, I'm not going to do this. So I think that really goes a long way, to give the client agency that, hey, I agreed to this, so now they're doing it. It's not them imposing this on me.
Right.
And then I think from an ICBT standpoint, and I know this is, you know, similar in ERP, but, you know, that self-trust, you know, yes, you may be in distress, but you can handle it. And so we want to teach the client they can handle distress, and also help the therapist have that trust in the client. You can be distressed, but you can handle it. The therapist trusts in themselves that I can sit with someone in this distress and tolerate my own distress of watching this. So a lot of self-trust and, you know, just a lot of agency for the client.
Right.
I like to involve, I always, if I can involve the family at any age, whatever age my client is, I'd love to involve the family, because OCD is maintained by family as well. And so it doesn't matter if they're a minor or if they are 50 or 60 or 25, family is important and friends are important. So I like to do also a hierarchy for family, how to remove accommodations and how to remove reassurance seeking. A lot of loved ones can't do all the things that would, in a perfect world for ERP, help the client. So, all right, so let's start doing these little by little. They're doing treatment, you're doing treatment. And then for what you said about the distress, I tell them all the time, you're already anxious. Yes, this is going to make you anxious, but you already know how that feels. You do it all the time. So would you rather be anxious and reinforce your anxiety, or would you rather be anxious with the purpose of it making it go away?
Right.
You're going to experience the exact same feeling. One is therapeutic, one is not so helpful. So
it's you know, I'm sitting here thinking to myself, I'm glad that we don't work together, because we would spend our entire time sitting together talking and doing no work.
Mary and I run into that all the time if we're in the office together.
Yeah.
We talk
We have
forever.
our meetings, and then somehow we're just like, oh, we forgot to do the stuff that we were here to do.
Well, maybe we'll have to turn this into a series instead of just, you know, one podcast. But let me ask this, because we're basically, you know, at our time limit today. But if somebody wanted to get in touch with you all, can you tell them how would they find you?
Absolutely. You can visit our website at www.anxietycentertampa.com. And we're also on Instagram at the @ Anxiety Center Tampa, and Facebook as well. So facebook.com/Anxiety Center Tampa.
Okay, so I want to make sure that it's clear. The website, it's Anxiety Center Tampa. It's not Anxiety Center of Tampa. So
Correct.
that they don't get the wrong
Correct.
address.
All the directions, Instagram, Facebook, and our website is Anxiety Center Tampa.
Perfect. Well,
can I just throw in something? So I mentioned the ICBT.online as a great resource. Just in case people don't know about the International OCD Foundation, iocdf.org, and there's also the Anxiety and Depression Association of America, ADAA.org, or I don't know if it's .com, but
it's ADAA.org.
And those are wonderful organizations. They have tons of information about OCD. They have therapists, directories. Anybody who's on any of those directories, I trust quite a bit. Right. In general, I mean, I can't say everybody, but so those are all really good resources. You know, the IOCDF has a lot of, we do a lot of advocacy and education and things. So each state has their own affiliate. Florida has 2 for some reason, but so OCD Central and South Florida is sponsoring, and all over the country, you know, we sponsor OCD awareness walks to raise money to help train educators, you know, train therapists, support family members, support individuals. It's a not-for-profit. If anybody wants to participate, we always need volunteers. You know, if you want to participate in a walk or donate or help with fundraising or anything, you know, it's a great organization, and we just need so much more awareness and training for.
And you can find more information. You can find more information about that at the iocdf.org website.
Yeah. I'm glad you mentioned that, because that is real important information. And most states have something similar, just like you were mentioning for Florida. So if you live in a different state, you can still go to the iocdf.org website, look up your state, and you can find the resources there. But yeah, the OCD walk comes up in September. October. Sorry, it's September now. It comes up in October of each year. And there's just like, there's so many resources out there. You just have to know about them. So,
yeah, and IOCDF does a great job of that. I just want to say in Florida, you know, the OCD walk is dependent on the hurricane season. Last year we were canceled because of Ian. Hopefully this year we'll still get to have it. So we'll see.
Yeah. Well, thank you both so much. This has been a conversation that I've wanted to have for such a long time, to be able to talk about the different types of therapy and compare and contrast. And you two certainly are, the right ones to be talking about it. And I'm so glad we had the opportunity. Certainly anybody in Florida, especially in Tampa, these are the ladies to go to if you have issues with OCD or anxiety. And I feel grateful that I've been able to speak with you all today. So thank you for taking your time to join me.
Well, thank you for having us, Andrew. It's been wonderful. Like I said, Mary and I can talk about this all day long. We love it. We're passionate about it. And I just love that you're getting the word out and doing this service for everyone.
Absolutely. Thank you so much.
Thank you.